We have Dr. Adam Price here, as many of you know, electrophysiologist with Cardiology Clinic of San Antonio. So he did do a presentation, I believe, last year for us here. So he's back here to give some more information. So welcome, Dr. Price. Thank you.
Can everybody hear me okay? Okay, all right. Yeah, it's very nice to be back. I appreciate the invitation. Certainly look forward to another kind of good conversation. As those of you who've seen me talk, either in the office or in this capacity, very informal. I like to answer questions. I'm going to go through some material, some of which is kind of similar to things I've shown, but certainly just to refresh people's memories of it. But I think more than anything, just to help everyone, have a structure to ask the kind of questions that are on your mind, certainly related to what I'm going to present, certainly anything else I can answer for you. With that said, we'll get started. So mainly, we're going to focus on AFib management today. I think the biggest focus on this talk is going to be more on stroke reduction, but we certainly also have a lot of things we can talk about that relate to, actually, keeping people in normal rhythm. We talk about medicines and ablations, things like that. I think my talk last time focused a little bit more on that, so today I was going to talk more a lot about just about Watchman. But we'll talk about, again, how does the heart work, what is AFib, how does AFib relate to risk of stroke, and again, basically the treatment options that are available to us. Okay. So obviously the basic anatomy, I've kind of shown some of these pictures for those of us who've seen me in the office and in prior presentations, but the heart is a 4-chamber structure. You have your 2 top chambers, the atrium. I don't know if I have a pointer per se, but your 2 top chambers of the atrium, and then your 2 bottom chambers of the ventricle. Historically, when we talk about where does the heart rhythm start, it starts in the top chamber in your right atrium. That's your sinus node. That's what's supposed to generate the electrical impulse. So when people go into AFib, basically what happens is that sinus node signal goes awry and the top chamber starts doing what we call fibrillating, where it's not really squeezing, the chamber is just kind of quivering in place. And that's what really leads to a lot of the issues that relate to AFib. So as you kind of see here, is there a pointer on this? I'm sorry. No, I think I'll just use the mouse here. So on the left side, that's kind of what a normal rhythm looks like. You can appreciate the cadence of those taller spikes, and that's really what we call the QRS. That's the lower chamber squeezing, but a very regular cadence to those beats. And then immediately before the bigger deflections, you see the little tiny deflection, which is the P wave. And the P wave is indicative of your sinus node firing in a normal way. So when you compare it to atrial fibrillation there on the right, in AFib, those complexes start to become much more irregular as far as the beat-to-beat variability. And then what you lose is that normal organized P wave, that little deflection in front of each of those bigger deflections. And so really the hallmark of what we call AFib is this irregular rhythm where there's just no rhyme or reason. Commonly the pulse rate is going to go very fast. And really what's occurring in the top is that the top chamber is no longer squeezing and pushing the blood. So when the blood stops kind of being transited out of that chamber in a normal way, that's what increases the risk of stroke. So as far as, again, what is the prevalence of this? The prevalence of this is quite significant. I had older slides I used to show in the past. This is probably more up to date. 10.5 million people more or less currently, and probably another 1.5 million up to 12 million by 2030. But very common arrhythmia. The statistic most of you have heard me say in the office, for those of you who've seen me there, 1 in 9 people at the age of 80 are going to have AFib. And if you look at a slide that shows age and incidence of this arrhythmia, it's an exponential increase kind of starting in your 60s. And that's all comers. It's not indicative of people who just have other heart disease. This is even healthy people. So it is absolutely a problem we see as we get older. I generally liken it to just sadly, anything that runs on electricity for 80 years, which is what your heart is doing, at some point, we're bound to see these problems happen. So we talk about different kinds of AFib. Historically, when people first start presenting with AFib on the left, it's what we call paroxysmal. Paroxysmal AFib is generally when you're kind of coming and going in and out of this on your own. The episodes tend to be short, all generally less than a week. We generally don't need to do anything to get you out of this. This is all happening spontaneously. But it kind of represents the earliest version of the disease. At some point, you transition more to the far right side, which is more persistent. This is when these episodes start lasting more than a week at a time, and that's typically when we also start needing doing things to get people back to a normal rhythm. Doing things can be anywhere from medications to cardioversion. Cardioversion is when we shock the heart electrically, and then all the way also to things like ablation. And then at some point, if again completely left untreated, or at some point just felt it's not amenable to treatment, you become permanent. Permanent AFib for us is when you're living in AFib all the time. You know, you're never in a normal rhythm, you're in AFib constantly. And at that point, it's also when we generally are no longer trying to correct the rhythm part of it. So things that contribute to AFib, you know, we certainly talked about age as the first one. Certainly other normal cardiovascular risk factors, things like high blood pressure and diabetes. There certainly is a genetic contribution. I commonly get that question in the office, you know, my family member has this, am I going to have this? It's not as straightforward as you're definitely going to have it, but there's absolutely genetic elements of this that make it more likely. In some very hyper-competitive athletes, we talk about marathon runners, there's actually a higher incidence of it. There's certainly a contribution to alcohol. Now, historically, I wouldn't say this is a one-drink problem. This is typically people who drink high volumes in a very repetitive fashion. And then certainly people with structural heart disease, patients with heart failure, patients with valve disease. These are things that also kind of contribute to it. Other things that aren't even listed here, we talk about sleep apnea. Sleep apnea is a huge driver of AFib. So commonly when you come in, you get your initial assessment. We like to talk about getting a sleep study, things like that for patients we think are at risk. What are the signs and symptoms? This is another big question. You know, a lot of times when people come in, a number of our referrals are people who are diagnosed with AFib who really was found incidentally. You know, they're in their primary care office, maybe they're getting a more routine medical procedure where they get an EKG, they're on telemetry. But a lot of patients really don't have any symptoms, and that's one of the more frustrating things with the disease. You know, you do hear about the historical symptoms of palpitations and shortness of breath and dizziness, but not everyone's going to have that. The reality is most of the symptoms are usually subtle. For some people, it's just fatigue, and again, for some people, there's just no symptoms at all. The biggest issue that comes with that is that if you have no symptoms and you don't know you're in AFib, then you're untreated for risk of stroke, and there's a lot of patients that come to our attention really where stroke is their first presentation. I have a whole separate talk where, you know, we talk about a lot of the newer technologies, things like Fitbits and smartwatches. I mean, these things are kind of raising our eyes to, you know, there's a lot of disease we can detect really before it's even clinical. And as more people adopt these technologies, we're also identifying a lot of people based on these things as well. So now we're going to get kind of more specifically into AFib and the risk of stroke. So certainly, you know, we know AFib increases risk of stroke by about 5 times. Now, AFib unto itself increases the risk, and then there's other things that further increase the risk. We have an acronym we use, it's called the CHADS-VASC acronym. Some people have probably heard me talk about this in the office, but it basically stands for heart failure, hypertension, age, diabetes, prior stroke, vascular disease, and sex. Women are at higher risk. So really anybody with AFib, you know, is at higher risk, but when we look at these other things too, we talk about what is your risk score based on that acronym. And certainly the higher the score, the higher your risk is going to be. So, you know, again, we obviously were talking about risk of blood clots, risk of stroke, and also, you know, symptoms that we worry about are related to heart failure. So as far as the blood clot risk and the risk of stroke, you know, the main part of the heart anatomy that we're worried about here when it comes to risk of stroke is your left atrial appendage. Using a little cursor there, if you look at the heart and in the left atrium, that top left chamber, you've got a little structure in there called the left atrial appendage. It's more or less like a vestigial portion of our heart. It's not really doing anything super useful. It's basically a blind-ended pouch that sits off that chamber. The problem is when you go into AFib and that chamber is no longer squeezing and, you know, pushing the blood out of the appendage, that's where about 90% of the strokes are going to form from this disease. We kind of derive that number when you look at surgical literature and patients who've had their appendage clipped off in the course of getting bypass or valve surgery. We've seen the risk reduction for stroke go down by 90%. So we basically have postulated that's where about 90% of strokes are going to form. And you can imagine if you put blood into this little pouch and that pouch is no longer squeezing, the blood is static. You know, static blood, if you've ever had a real bad cut or bleed, it loves to just stick to itself and form a clot. And the problem is if that clot embolizes, that's where a lot of the stroke risk comes from. And so that's more or less kind of where we derive the idea for the Watchman procedure. Again, the kind of data about 1 in 3 people with AFib may have a stroke in their lifetime. We talked about the 90% originating from the appendage. Certainly symptoms of a stroke, I know have probably been talked about here previously. I know we talked about that a little bit a year ago. Certainly blurred vision, weakness, altered speech, difficulty ambulation. Really identifying those symptoms is of critical importance to figure it out quickly to get treatment. Treatment of an acute stroke is certainly a separate talk, but certainly as it relates to having AFib and recognizing the signs, as anybody with AFib is at higher risk to take these things very seriously. So we talk about kind of treatment options. You're basically divided into 2 groups. We're going to focus more on stroke risk in a moment, but we certainly talk about how to keep people in AFib in a normal rhythm, especially as it relates to having symptoms. So again, heart failure symptoms, shortness of breath, fatigue, palpitations, any of the symptoms that drive people to need to go to the hospital or affect quality of life. The goal behind that is to try to keep the rhythm more normal. But the bigger issue we're talking about is risk of stroke. How do we prevent people from having a stroke when they have AFib? And so basically, the rate and the rhythm control will kind of come back. I'll pull up a different talk to get more into those things, to be honest. But as far as prevention of stroke, historically what we're really focusing on is either the usage of blood thinners, which has been generally the mainstay for the longest time, going back to Coumadin as being really the initial anticoagulant, and now more commonly drugs like Pradaxa, Eliquis, and Xarelto, but comparing them to really what we've had now in excess of 10 years, which is the Watchman device. So the whole idea behind blood thinners is that if the blood in the appendage is not moving very well, and we want to do things to make it a little less okay, perfect. So if the blood is basically static and not moving, when we put people on more potent blood thinners, it just keeps the blood from sticking to itself. So you're not going to form the clot, and by not forming the clot, your risk of stroke is going to go down. So the problem becomes, what if patients are not good candidates for blood thinners? And obviously this is for a whole host of different reasons. Certainly just people at risk of falls, people with a history of GI bleeding, history of intracranial bleeding. Some people have other medical disorders, hematologic disorders, where again, it's just not appropriate to be on blood thinners. Sometimes it's lifestyle driven. Some people have a very active lifestyle. Some of their hobbies put them at much higher risk to have a fall and a bleed. They like to bicycle or exercise or do things outdoors. So there's really just a very long list of reasons. And those are the patients we typically will talk about. Are you more suited for a Watchman device? So, back to blood thinners. A lot of times we get asked questions in our clinic about, is aspirin adequate? Generally that risk is based on what is your risk of stroke in AFib. So going back to that acronym we talked about earlier, as far as, again, if you have more risk factors like blood pressure, diabetes, or prior stroke, we know that aspirin really doesn't do justice to that risk. And so that is why we initially will talk about Coumadin and Eliquis and Xarelto and those meds. Again, Coumadin, most people are familiar with. It's been around a long, long time. Coumadin, very inexpensive as a drug, but obviously the quality of life issues that come with needing to get your blood checked, needing to be dogmatic in how you look at your diet, and also just the peaks and valleys of these numbers. It's a drug that's very heavily influenced by metabolism and things you eat. So Coumadin is a very challenging drug to work with. And so gratefully, we do have newer agents, drugs like Eliquis and Xarelto, which the dosing is much more reliable. The data for them in terms of safety and bleeding compared to Coumadin is certainly much better. The problem with these drugs, sadly, is cost. Cost of these drugs, they're all generally mostly brand name still, and so they can be very cost prohibitive for a lot of patients. Okay. So, that takes us into talking about some of the newer agents, like we just said. Again, people who've seen me in the office, we generally talk about it's almost like a risk stratification model. Whenever anybody has AFib, we talk about the pros and cons of going on blood thinners versus not, or going on blood thinners versus maybe the alternative of the Watchman procedure. Generally speaking, the data favors using blood thinners. There's always going to be some patients that it's really just too high risk, and certainly we're going to respect everyone's judgment when we have that conversation, but it's certainly a conversation I think that's best had with probably your primary care doctor, as well as someone like myself who understands kind of what the literature says and how these things kind of typically go. But certainly in patients that we don't think are well suited to be on long-term blood thinners, that's who we talk about the Watchman procedure with. And so basically it's a comparable way to reduce the risk of stroke, but without committing you to long-term blood thinners. That's the idea behind the procedure. And as we kind of showed in that picture, if you can close off the appendage, which is where 90% of these strokes are coming from, it allows us to both prevent stroke and get you off the blood thinners. There we go. So when you talk about the success rate of the procedure, and we'll get into the procedure a little bit in a bit, success rate is in excess of 95%. You know, these are patients who undergo the procedure, and generally within 45 days, we're able to stop their, whether it's Coumadin, Eliquis, or Xarelto. We still do need to keep people on about aspirin and Plavix for up to 6 months. But as far as the success rate of getting the device put in and being able to come off blood thinners, the success rate is quite high. The implant procedure, you know, for people who've had a catheter-based procedure, it's kind of similar to a heart cath in some respects. It basically involves getting vascular access to the little femoral vein. Now, for our procedure, we do typically do it with anesthesia. You know, for us, it's a combination of helping the patient just be comfortable, not needing to worry about moving on the table. It also just helps it be a lot more efficient. So typically when you come in and do this kind of procedure, we'll have anesthesia support. But basically it just involves placing catheters in the femoral veins, the idea being that we're going to go bring these catheters up into the heart. Because the appendage is on the left side, we do have to cross over from the right to the left and get into that chamber. And then using a combination of fluoroscopy, which is live x-ray, as well as intracardiac ultrasound, we can basically image, and that's how we basically select the right device. Everybody's appendage is a different shape. I got this question just earlier before I began. So, you know, again, the Watchman device comes in different sizes. That helps us accommodate different anatomies, different size of the osteums. And generally speaking, again, we're able to close them at a very high success rate. Those are things, again, we all kind of derive during the procedure. Years ago, we used to do more pre-imaging. These days, generally, we're pretty good at closing them, so we don't typically have to do scans in advance, whether it's CT scan or ultrasound. We're typically imaging this as we go. And so, you know, sometimes when people come into the room, you know, we do identify if you've been off blood thinners, sometimes people can have clots. Clots certainly limit our ability to put in the device in the acute setting. So I really emphasize when I meet people in the office, if you're not on blood thinners when we start talking about this, we're going to need to put you on blood thinners generally before the procedure. Now, immediately after the procedure, that regimen, again, can vary a little bit depending on your risk. But for the most part, I do like people coming into the procedure to already be on anticoagulation. You know, again, this kind of outlines a lot of what we were just talking about. After the procedure, if someone's doing well enough to stay on Eliquis or Xarelto for that 45 days, that's typically what I try to do. There are some patients who are such high risk, I may immediately take them off that and go to aspirin and Plavix as the alternative. But I would say for the most part, if you're tolerating it well enough, we try to do that for another 45 days. At 45 days is typically when we're going to re-image. So usually as an outpatient, one of my other partners, someone like Dr. Fletcher or Dr. Prieto, we basically have them come in and we do what we call a transesophageal echo. That's an echo where we're actually looking down the throat. Because of the anatomy of the heart, the appendage is actually very posterior, and so it's much harder to image it looking through the chest than it is down the throat. So when we come in and we go look at the device about 45 days later, we typically do it in that way, but that fortunately is outpatient. There is, of course, sedation we use during it, but it's pretty much a quick in and out thing, and you get the feedback right away from that. So certainly, you know, like any invasive procedure, you know, risks. I generally quote people the same risks I would for a normal heart cath. Anytime we get vascular access, risk of things like bruising, bleeding, vascular injury. I'm pretty meticulous. We use an ultrasound every time to visualize everything, but the risk of those things is still about 1%. As far as more significant risk of injury to the heart muscle as we're deploying the device, as we're manipulating things inside the heart, risk of more severe injury to the heart, things like a tear or perforation, are probably about 1 in 500 to 1 in 1,000. I generally quote the same risk of device embolization. You know, that's certainly a concern when we deploy the device. We want to know that it's secure. We have a lot of different tools we use to kind of make sure the device is secure. We make measurements. We do what we call a tug test to really make sure it's holding onto the tissue appropriately, but there is still a very limited risk of that. Risk of dying from a Watchman procedure is exceptionally low. So all in all, it is a very safe procedure and a very successful one. I'll show you some other videos in a different talk. I'll show you a deployment. But yeah, I mean, it's been used clinically here, I think in San Antonio, in excess of 12 years now. You know, it's certainly something we have a lot of experience. We're already on, I believe, the 3rd generation of the device. So things that have evolved in terms of safety, in terms of how the device is structured, have made it even a safer implant technique than what we did initially. And I think it's borne out that, yeah, I mean, most patients who've undergone it, I think, have had a very positive experience for it. And so again, kind of coming back to, again, who are the appropriate patients? I mean, typically these are going to be patients with AFIB at higher risk of stroke because of their AFIB, you know, who obviously have a rationale for seeking a non-oral anticoagulant approach to kind of managing the risk of stroke. These are, again, risk of falls, risk of bruising, risk of bleeding, other GI and intracranial bleeding. You do need to be able to tolerate blood thinners, like I said, though, briefly. You know, post-implant, we do need to keep people on medicines while the device is healing. So someone who's completely unable to tolerate blood thinners in any capacity, I've had a rare case over the years where we just can't offer it. But for the most part, most people are able to tolerate these drugs in a short enough span to be able to tolerate the procedure. Patients who are not candidates, like I said, somebody who really can't tolerate any kind of bleeding, patients who for whatever reason can't tolerate the procedure. And the scope of procedures, because of how minimally invasive it is, it's rare to find someone who really can't tolerate it. The device obviously being made out of what it's made if you're allergic to nickel or titanium, which is pretty uncommon. Rarely, again, we'll stumble into somebody's anatomy who just isn't conducive. You know, rarely maybe the ostium is just too big to accommodate the biggest device, or just too little, or sometimes just the anatomy of how it takes off. So every now and then you will still stumble into someone that just can't be safely implanted. And you know, you never want to leave a device in someone if you're not totally confident it's going to do the right thing and stay in place. So those are the big ones. And then the other one, you know, sometimes we get patients who are on blood thinners for other reasons. Patients who've had a pulmonary emboli, patients with other hematologic disorders, or they're very prone to clotting. You know, obviously, if we're going to put in a Watchman and you need to stay on blood thinners anyway, we're really not doing anyone a service at that point. So we've certainly seen our share of patients over the years where it's just, you know, if we're not going to help your management, if I'm not going to get you off blood thinners, then the risk of the procedure really doesn't seem to make sense in that population. As far as coverage, yeah, it's extremely rare that we have patients who are denied for Watchman anymore. Years ago, we used to have a little bit more, I don't want to say scrutiny, I don't know if that's the right word for it, but certainly insurers wanting to make sure. I think it's been a couple of years since I can remember anyone really being denied for a Watchman. And so, yeah, I mean, as far as, again, you know, having this conversation, I think anybody with AFib, anyone on blood thinners should be constantly vigilant to just kind of really think about how are they doing on it, are they having problems with it, at minimum being familiar with this. I have a lot of patients who, they get minor bruising and bleeding, but it's still acceptable. They've never had a big event. They've certainly never needed to hold the blood thinner because of those things. Those are patients I'm generally very comfortable staying on blood thinners. You know, I think the ones that I typically am going to focus on more are patients who've had really horrible falls, really horrible injuries, patients who've had to discontinue blood thinners for other reasons where they're then unprotected against the risk of stroke during those intervals of time. Those are the patients I'm going to be a lot more focused on saying, hey, look, I think you're a good Watchman candidate. We really need to start this conversation. And even then, even like I do with AFib management, a lot of times it's starting the conversation, and then over time you see how things go. But I think the important thing is being familiar with this option up front, because a lot of people start on blood thinners at a point in their lives where they do fine on them. They're active, they're not at risk of falling, but sadly, as we get older, things do change. And I think just knowing that this is an option at any point is probably the most important take home. Yeah, just some general other info, but I'm happy to answer questions on this. I've got another presentation I've showed in the past where I show some deployments inside the lab. I can show some ultrasound images if people think that would be helpful, but otherwise I'm also certainly happy to answer questions.
What about the success rate for long-term, like 10, 20 years? Does the implant dislodge, or does it ever have to be replaced?
Yeah, No, the implant is permanent. The risk of dislodgement is more of an acute phenomenon. Once the device is in, what basically happens over time is your body endothelializes over it. So in essence, you grow tissue over the device. So really, once it's in place, it's in place. It's permanent, never needs to be, replaced later. I describe it's like a mechanical plug. The device isn't actually doing anything to you. Some people, have a thought, is it doing something? Does it run on batteries? It's just a mechanical device. It just stays in place. And over time, when you image them later, once it's sealed, we'll do CT scans for other reasons. And what you see is that the appendage is basically excluded from the circulation. And so really, yeah, if you're cutting off the source of 90% of those strokes and they're gone, then it's gone.
So it's kind of a different way of amputating the appendage.
Correct, yeah. I mean, surgeons, when they go in now, they have something called an AtriClip, where they clip it from the outside. This is just an internal way of doing it. And again, there's, some people get surgery for other reasons, bypass and valves. We highly encourage the surgeons at this point to please put a clip on it, mainly because the appendage is doing so little for us otherwise. So yeah, I think certainly here in town, the surgeons we work with in Methodist are extremely proactive in doing that. But for patients who don't need surgery, I think this is a wonderful alternative, a minimally invasive one that tries to accomplish the same thing. Yeah.
I take risperidone,
Mhm.
and that does cause bleeding problems. Would that be a problem later down the road? Because I have congestive heart if I needed a Watchman.
No, I mean, as in would it limit your candidacy for it? No, that would be fine. I mean, we certainly, I can't quote the number, but I'm confident we've had people over the years. I mean, certainly patients with heart failure, this is not an uncommon phenomenon. A lot of heart failure patients will get AFIB. And even with risperidone and other medicines, we've never had a scenario where I don't think you'd be a candidate to get the implant.
Okay, thank you.
Yeah.
MRIs after the Watchman procedure?
Yeah, it's safe. We typically, I think, encourage waiting about 6 weeks. But it's a safe device to get an MRI in.
Would you mind putting the BFAST slide back up, please?
Sure.
I have a question. I want to make sure I understand. I have a Medtronic pacemaker. How is it different from a Watchman?
So the pacemaker obviously is more designed to kind of help regulate the electrical properties in some respects. So, pacemakers can go in for a number of different reasons. Historically, you're talking about patients with symptoms of a slow heartbeat. You can get slow heartbeats for different reasons. Is that showing? Yeah. So, again, the conduction, the way the heart works electrically, you have different ways to get a slow heartbeat. So sometimes it's your sinus node, which is your own intrinsic pacemaker, will go slow. Sometimes your AV node, which is basically the gateway from the top to the bottom. The bottom chamber really is what's responsible for your pulse. Sometimes the AV node doesn't work well, but the idea of the pacemaker is it's trying to restore normal communication in the context of something that's not beating fast enough, make sure it's going to stimulate. The important thing with pacemakers, pacemakers themselves don't prevent stroke in any capacity. It does allow us to help regulate the rhythm a little bit in some cases, but certainly doesn't do anything to prevent stroke, whereas the Watchman, it prevents stroke, but it has nothing to do with regulating the rhythm. Some people come in and they ask, well, will this cure my AFib, a Watchman device? No, I mean, it will do nothing for that. So I think that's an important way to differentiate when somebody comes in and they're very symptomatic from AFib. Those are the patients we're also really going to talk about, are you a candidate for ablation? Are you a candidate for antiarrhythmic drugs? Something to actually help your quality of life. I mean, I would argue acutely putting in a Watchman device doesn't necessarily make you feel better, but certainly it's going to lower your risk of stroke, get you off blood thinners, and there's absolute quality of life benefits to those things. But if you're symptomatic from AFib itself, we also want to talk about how do I get your rhythm back to normal, and that's the other half of what we talk about.
If you've had a previous ablation and the AFib comes back down the road, would you be a candidate still for this device?
Yeah, so this device, I mean, we've had patients who have ablations or any intracardiac procedure. I mean, none of those things limit your candidacy for this. The only things that would limit your candidacy for this, if someone's had a procedure related to their appendage, rarely we'll see some patients who have had that surgical clip put in place. It's maybe not adequately enough closed. But once you distort the appendage and it's shrunk down, then understandably we can't put this in. But just simply having an ablation, having a pacemaker, having a stent, you're still absolutely a candidate for the Watchman device.
Is an amulet just another kind of Watchman?
It's in the same space. We call these like left atrial appendage occlusion devices. So the amulet is a different version of it. It's made by Abbott. All these devices, they all have different kind of structure to them and the way they're conformed. And, certainly, every now and then, some of that, maybe 4 or 5% of people that maybe aren't able to be successfully implanted. It's a low number, but sometimes the anatomy of the appendage facilitates maybe a different device may do a better job. This is, kind of even though it's been here over 10 years, it's still a relatively newer space. Again, we're already on multiple generations of the Watchman device, but yeah, certainly there's going to be still more developments ahead in the amulet's just a different version of the same principle.
They did an amulet because they didn't have the right size Watchman.
Yeah, and so
They've got new sizes now.
Yeah, it goes up to 40 millimeters. Yeah, so, and that was about 1.5 years ago, give or take. So so again, one size isn't fits all sometimes. So yeah. Let me see if I can pull up the other talk, and I'll just show a deployment, and I'll show some other images here. Is it not sharing that? That's I have it on my screen, but it's obviously not there. No. Is the IT gentleman still in here? Okay. Well, all right. I've got some other ultrasound images on a different talk that I showed here 1 year ago that shows how we deploy the device under X-ray and all those things. We can't pull that up, but yeah, I mean it's pretty neat imaging. We're using ultrasound, we're using live X-ray. The device deployments, we get an acute sense of how do we close it. We inject contrast into the heart to kind of confirm we're not getting dye to fill into the appendage. Simultaneously doing ultrasound imaging. So, we use a lot of different ways to kind of make sure we're getting the outcome we want. And again, in the extremely rare cases where we don't feel confident in the level of closure, those are the rare cases where we're going to say, look, we're not going to leave a device in we're not 100% confident in.
There is an animation video in that previous, you might be able to pull that up.
Okay.
Not going to be as good as yours, but.
Let's see something.
We're working on IT, sir.
Okay. Because I know I'm not IT, that's for sure.
Someone's coming.
Okay.
Dr. Price, we have another question while we're waiting.
Yeah, absolutely.
So how long does the procedure itself take?
So the average procedure time, I mean, if you take out just getting under anesthesia and getting our patches, the average implant time, honestly, is probably about 40 minutes. Yeah, no, we've gotten a lot more efficient, I think, as the tools have gotten better, our imaging has gotten better. I'd say total time in the room when you factor going under anesthesia, being intubated, and then of course being woken up, you may be in the room a little over an hour, hour and a half. But I'd say for a straightforward implant, pretty straightforward anatomy, they're generally very, very fast.
How often do you abort the procedure because it doesn't fit, it doesn't fit, does it whatever? Are those decisions usually made before from imaging?
So when we initially start the procedure, we initially get vascular access, and we'll initially ultrasound image it from the right side of the heart, the right atrium. I mean, in the course of a year, the things that would get us to abort at that phase is usually only if you have a blood clot. And again, that's pretty rare. Most of our patients are coming in, they're on anticoagulation, but rarely we'll find someone who, again, we had someone just a little over a few weeks ago, extremely high risk to be on blood thinners. We talked about it ahead of time. We kept them off blood thinners until implant. That person unfortunately came in and they had a blood clot, so we didn't do anything further. As far as once we're across, I mean, the number of patients that we're not able to successfully implant is awfully low. I mean, I'd say it's less than 5%. The vast majority, once we're in and there's no blood clot and we move forward, most of those are going to be implanted.
So you just back out at that time and.
Yeah, we remove the catheters. We use little collagen plugs to kind of seal up the veins, and and those images usually we get efficiently enough. It's within a few minutes. If we image it and it doesn't look good or appropriate, there's some rare cases, somebody who's super high risk, can't get rid of blood clots. We've had a few partners do some things at the bigger medical center. They can put in what we call cerebral protection devices if there is a clot, but you still somehow need that Watchman that badly. But those, we generally don't try to do those cases. I mean, those are.
Is the size determined before you go in with imaging?
It's during the procedure generally, yeah. So, yeah, combination of live X-ray and the ultrasound images, that's how we determine the sizing.
Dr. Price, if you've had a valve replacement, are you a candidate for a Watchman?
Depends on the kind of valve and the reason. So if it's a mitral valve and a mechanical valve and you need to be on Coumadin, then obviously Watchman becomes irrelevant. It's kind of like similar to the patients who've had clot, like pulmonary emboli. If you have another reason to be on blood thinners, then I would say no, it's not appropriate. But if you've just had a bioprosthetic valve, aortic valve, then no, those are patients that are still reasonably appropriate for it. So it really just ultimately comes down to what is your reason for being on blood thinners, but as far as the valve actually limiting our access to do what we're trying to do, no, that shouldn't be an issue.
I'll talk to Dr. Canales about that next
Sounds good.
appointment.
Please do. All right, just trying to pull up a different talk, actually. Are we on the right one? There we go. Okay. I'm going to kind of skip ahead on this one just to get to just the deployment images. Any other questions though in the interim? Yeah.
Yes, could you give us the pros and the cons of blood thinners, please?
Yeah, so the pros, I would say certainly if you have a condition, and again, I'll specify more or less for AFIB since that's what I'm managing. The pros are that, look, if you have AFIB and you're at a much higher risk of stroke from AFIB, the blood thinner is there to help reduce your risk of stroke. The cons are obviously like any medicine, especially being a blood thinner, the risk that it does of increasing your risk of bruising and bleeding. So, if you have a fall or a minor trauma or some other condition, being on a blood thinner is generally going to amplify your risk of bleeding in that context. So that historically is the downside. Other downsides we talk about is just, look, the need to be on medicine, period, the quality of life cost of that, the actual cost of taking blood thinners themselves, the financial cost. But the pros are really just, look, if you have a condition that warrants being on blood thinners, we want to do something to prevent stroke. So that's usually how I would kind of put it together there. Sorry, it's a little ways into this. So these are ablation images. We can talk a little bit about that too. All right, so basically to show you, so this is again a depiction of the appendage itself, obviously an artistic rendition, but where the clots are going to form. These are ultrasound images of basically the appendage, and you can see a blood clot sitting inside of it. So, and these are obviously histological, like actual pathologic specimens of what a blood clot looks like, and obviously these are things when they embolize, you can imagine the devastation they come. And so, we know that very little amounts of AFib obviously dramatically increase your risk. And so, again, when we're talking about really how the Watchman procedure is going to work, here we go. And And so this is the latest kind of version of the device where it's kind of more folded in on itself on the back end here. You've got these little tiny tying hooks there that help kind of fixate it in position. But the idea is we're going to bring a catheter up and deploy it inside the appendage there where we can fill that whole space and simply prevent blood from coming back and forth. So here we go. So these are the images now of deployment. So what we first do is, we deploy a catheter up into the appendage where it's basically, we're going to do what we call a venogram or an angiogram of the appendage. We're going to instill dye, and that's going to help us characterize, again, the general size and shape, and we get to measure the osteal width. And that's going to help us choose the right size of device. And then basically we get to the deployment phase, and I know a little hard to totally make it out, but what you basically see in the start of the image, we withdraw the sheath. I kind of liken the device almost comes as a collapsed umbrella inside the sheath. It's kind of a spring-loaded device that as you withdraw the sheath, then the device springs open, and you can appreciate that right in just a second here. Yeah, kind of springs open, you see that. And then at the end, we basically do a tug, and then we want to make sure that the device itself is secure, and then we'll do a fluoroscopic shot. We'll push in the dye, and as you can appreciate here, the dye is filling this appendage. At the end here, no dye is getting past this device, so we know the appendage is basically closed. So afterwards then, we take ultrasound images where we can image the device. You can see the little shoulders of the device and the core where the wire attaches. And as we image it in different planes, you can see that the appendage is now closed. This is a CT rendering of someone who couldn't do a TE afterwards, and you can appreciate the Watchman device here. You can see the little nitinol, but no contrast is getting in and filling the back end of the appendage there. So there are a lot of different ways to image it after we're done with it. I know some people really don't like the idea of having a probe put into their throat to do the ultrasound picture, so we can do a CT scan. Things that limit a CT to me, it gives you radiation, it gives you contrast. If I don't need to do those things, I try to avoid those things. The nice thing about ultrasound is it doesn't expose you to any radiation or dye, so that is our preferred modality, but some patients are unable to do it, so we can do a CT scan in those patients. All right. Any other questions at this point? I can certainly talk a lot about ablation too, if that would be helpful. Yes? Okay. All right. Question?
If you have a pacemaker and a Watchman, how long do you have to be on aspirin?
So the recommendations, even at the end of the 6 months after you get the Watchman, we still generally encourage aspirin.
Why?
It's what the data typically says. I mean, again, the appendage is where 90% of the strokes come from. It's not 100% of the risk. It's not 100% that it's going to resolve everything. So typically we still encourage low-dose aspirin. Now that's still somewhat case dependent. I've had patients over the years, if they're really even intolerant of aspirin, we've had that same risk discussion, and there's some patients I will take it off if they're really that intolerant, but the guidelines generally still recommend we keep you on a little aspirin at the end of the 6 months still. Not a fan, yeah. I gotcha.
If you have congestive heart and you're not on any type of medication, do you need to be on aspirin then?
If you just have heart failure but not AFib?
Right.
No. I mean, the guidelines for aspirin use in general have become way more conservative. So years ago, yeah, everyone is told, oh yeah, go take aspirin. These days, no. Unless you have a real compelling reason to be on it, yeah, we generally discourage it. So if you don't have a stent or anything like that, yeah, just having heart failure alone, you shouldn't need to be on it.
Dr. Price, we have another question.
Yeah.
Do you still need to be on a rhythm drug then with this blocker? I mean, this appendage blocker?
As far as, okay, so.
Like the Voltac.
Yeah, so the way I liken it, again, there are two elements of the same problem. So someone who's truly asymptomatic with their AFib, look, the Watchman device, if we can get you off blood thinners, it's a great option. do you need to be on antiarrhythmics? A lot of that is going to be based on, are you having AFib and are you symptomatic from it? So if you're symptomatic from AFib, then that's where we talk about strategies. How do I keep your rhythm normal? And whether that's a drug like Multac, flecainide, amiodarone, or alternatively ablation. But no, I mean, having the Watchman doesn't require you to be on Multac. It really comes down to, are you symptomatic from the AFib itself, and how do we want to manage that part of the problem?
So, maybe not. I hate Multac. It just interferes with a lot of other drugs and blah, blah, blah. Or the statistics, the studies say that.
Yeah,
How much
well,
it does.
and that's why there's a lot of other treatment options other than drugs like Multac. And those are patients, again, we talk to about ablation. You know, when you look at what we can accomplish with ablation, ablation has always done better than all of our medicines. Let me try to get to the point of the slides I'm trying to get to here. There we go. Okay, we'll start from here and go forward. So, when we're talking about, again, antiarrhythmic drugs versus ablation, for a long time, antiarrhythmics were really the only good option. Catheter ablation of AFib really started to pick up steam in the early 90s and especially in the 2000s. Obviously, the pros and cons of medicine versus ablation. If you look simply based on efficacy and what works best, ablation has always done better than medicine. The best drug in the best scenario still only works about 50% of the time, and that's a drug called amiodarone that has a lot of toxicities and side effects. Even the more benign drugs, they cost money, they have side effects, and again, the best case is they're going to work half of the time. When you compare to what we do with ablation these days, and ablation has come a long way, and we'll get to PFA in a moment, upside of doing ablation early on when you're more paroxysmal, this is that earliest version of AFib we spoke about when you kind of come and go in and out of it, you're not spending a lot of time in it. Our success rate in that population is going to be about 80 to 85%, meaning we do an ablation, we keep you in a normal rhythm, and we can get you off of drugs like Multac or flecainide or whatever antiarrhythmic you're talking about. So this is kind of the procedure. I think I've got a image. These are older images now as far as a case and how this kind of works. But the idea is, similar to having a Watchman, this is a catheter-based procedure. We're going to get vascular access. We do these under anesthesia. The idea is we're going to make an electrical map of your heart. We know from 25 plus years now, nearly 30 years, I'd say, there are characteristic areas inside the heart where AFib is going to come from. And so looking at, this is me doing a case from years ago, we're going to use this catheter, we're going to recreate the anatomy. You start to see these areas, these little outpouchings here. These are the pulmonary veins. This is where about 80% of AFib is going to originate. The originating issue is you get basically an electrical impulse inside of that vein that fires abnormally. And it's that signal is what then precipitates you to go into AFib. So when we do ablation, the whole idea is that we're basically trying to isolate the problem areas of the heart, the areas that typically precipitate it. And so this is kind of us making an initial pre-map where we're just trying to define the anatomy and define where the veins are. What's neat is we do this all with three-dimensional mapping and ultrasound. This is very little, if any, fluoroscopy. So even though you're in a fluoroscopy suite, we're really not giving you any radiation. We're also really not giving you any contrast or dye compared to other heart catheterization procedures. So the idea is then, historically, and then we'll get into what we're doing more now, historically we used to then take a catheter and point by point deliver radiofrequency heat lesions, or in the case of cryoablation, we put a balloon which would freeze and we would freeze that tissue. But the idea is that we're trying to electrically isolate the vein pairs, and so that's what we've done here. Once we've done that, we then kind of put the heart through certain pacing maneuvers. We put you on adrenaline medicine. We're also trying to look for any other replicatable arrhythmias, things that also might be related to why you have AFib, and treat that at the same time. So for a long time, this was the standard of care. We did it with heat or we did it with freezing. And these procedures would take, anywhere from 2 to 3 hours sometimes, depending on how much AFib you've had, your individual anatomy. And so, but it was still certainly an excellent way of treating it. And for patients who didn't like side effects of medicines weren't working, this is absolutely, I'd say, the standard of care, and this is a class 1 indicated procedure now. So at least where things have evolved since, this is just kind of turning the map around a little bit. This is historically comparing heat versus freezing, but kind of where things have evolved to, and that's where I'm going to get into more novel things, really something called pulsed field ablation, which we've been fortunate over the last about year and a half to have access to now. Pulsed field ablation has basically revolutionized what we've already done with AFib ablation and made the procedure definitely quicker and definitely safer. It's different things. So this is kind of pulsed field ablation. So it's the same idea. It's still a catheter-based procedure. We're still going in through the veins. We still typically do this with anesthesia just for patient comfort. But instead of heating or freezing tissue, what pulse field does is it delivers very high voltage, and we're basically creating a different mechanism of injury. So when you deliver high voltage against the tissues, you're getting what we call electroporation. The cell membranes open up, and when the cell membranes open up, that's how the cells are injured. So the nice thing is if you're not heating or cooling things around the heart, the risk of collateral injury now is basically zero. So a lot of the historical risk of the procedure related to injuring the esophagus, injuring your phrenic nerve. So these risks gratefully now are basically non-existent. And because of the way this delivers energy and creates injury, it's also much, much faster. So a procedure that used to take us 2.5, maybe sometimes 3 hours, are now down to like 60 or 90 minutes. And so from that perspective, I mean, it's good as the patient, it's safer. It's good for the patient too, it's quicker. It's also good for our ability to care for a lot more people. You know, I showed that slide early at the beginning, the number of people who have AFib these days. I mean, it's honestly overwhelming, and in the past when we were limited in the length of the procedure to get to people timely, I used to have to tell people in my office, yes, we want to do an ablation, but yes, it's going to be over 2 months from now. Fortunately, with these newer technologies, we're able to get the throughput down, and you know, most people are not waiting nearly as long as what they used to do this. And purely from just a quality of life perspective, if we can get you off drugs, keep you in a normal rhythm, keep you feeling good, that's the goal. You know, I don't ever tell anyone this is a life-saving procedure. It's definitely a quality of life procedure. And you know, for patients who've dealt with symptomatic AFib and know just how bad things can feel, getting hospitalized for heart failure and AFib, needing to take the antiarrhythmics and all their side effects, this is an awesome treatment modality. Like anything, you know, the earlier we do it, the better the outcome. When we talk about 80-85% success, those are typically patients who come in early, want to be proactive, and want to deal with this disease when it's in its earlier stages. Like anything, the longer you wait to treat it, the outcomes tend to not be as good. So someone who's been in AFib and become more persistent, been in AFib more than a year at a time, that 80-85% number can drop to like 70%, if not less. It doesn't mean we don't offer it, but those are the patients I typically have to build the expectation, look, we may need to do this more than once. You know, patients who have really big atrium, when we get echocardiograms, or even just when we're doing the procedure, the bigger the atrium, again, it just implies there's more stretch, there's more disease progression, and those patients typically we need to consider doing it more than once. But I generally put the desire to do it based on symptoms and quality of life. I see a lot of patients who come in, they're in AFib, they feel great, you know, they lead a full life, they go exercise. If you've been in AFib for years and you come in with that story, those are not patients I'm probably going to encourage to go do these things. But certainly someone who comes in, they don't feel good, they're in heart failure, they have edema, they're ending up in the hospital. I know you may not feel the classic, my heart is racing, but again, the fatigue and the breathlessness, those are compelling reasons to say, should we do something to get your rhythm back to normal and see if we can help you feel better.